Hello everyone, my name is Taylor Watterson, a PhD candidate at the University of Wisconsin-Madison, and I'm excited to share with you findings regarding CancelRx, comparing frontline and leadership perceptions of health information technology implementation using quantitative ethnography. When a patient is seen in their physician's office or outpatient clinic, the prescriber will routinely discontinue or stop medications. These prescribers will discontinue the medications electronically in the patient's electronic health record, or EHR. Although these changes are documented in the clinic system, there previously was no automatic transmission of this information to the community pharmacy's dispensing software. This creates uncertainty of whether or not the pharmacy are informed and often leads to discrepancies between the active medication lists across clinics and community pharmacies. After a prescriber has decided to discontinue a medication, a cancellation message is sent from the clinic to the pharmacy, and a staff member must manually mark the items as canceled in the dispensing platform to block the prescription from future refills. Within the last decade, a new health information technology, or health IT functionality, termed CancelRx, has emerged to electronically send a medication cancellation message from the clinic's EHR to the pharmacy's dispensing software and automatically discontinue the prescription. Implementation science principles emphasize the importance of considering the frontline workers when preparing to roll out new, innovative practices. The Systems Engineering Initiative for Patient Safety, or SEEPS model, is one way to think about work systems as they relate to patient safety, especially new health IT initiatives. And so for this study, we used the SEEPS model and quantitative ethnography to compare frontline and leadership perceptions of CancelRx implementation. CancelRx functionality was implemented in October 2017 at an academic health system. CancelRx was implemented as part of a larger EHR upgrade, and so all clinics and prescribers all had access to this new functionality at the same time, as compared to a piloted or phased-in approach. At 9 months post-CancelRx Go Live, our research team interviewed a convenient sample of pharmacists and community administrators from the academic health system's outpatient pharmacies. The pharmacists and administrators were asked questions regarding the prescription dispensing process, communications with other healthcare providers, the medication cancellation process, and more. Rather than analyzing the interviews in a traditional qualitative manner, we used a novel approach to quantify the text using a mathematical model. Quantitative ethnography, specifically epistemic network analysis, is a technique to model the structure of connections within data. In this way, quantitative ethnography and epistemic network analysis provides us with a systematic way to compare networks and understand how connections differ between people. In this case, we're comparing frontline and leadership perceptions of CancelRx using interview text data. So, to start this process, our interviews were audio recorded and transcribed. This screenshot may look similar as a typical transcript output, a Word document. There's one document for each interview. The speaker is bolded in some fashion, and then the text. But this needs to be transformed in some way to be able to assess it mathematically. Enter the spreadsheet. Now we've turned the textual data into something that can be analyzed via a statistical platform. You'll see that our dataset has the following column headers: row ID, date, time period, location, respondent ID, speaker, and then text. One of the key decisions you have to make in quantitative ethnography is how you're going to segment these lines or rows. What counts as a row of text? Is it a turn of talk, so everything the interviewer says and then everything the respondent says are each in their own line? In our case, we decided to segment based on sentences, breaking everything apart by end punctuation marks such as a period or question mark. This was chosen because sometimes respondents would provide long responses, which is desirable in an interview, but it was too hard to analyze in big chunks. Next, as with a more traditional qualitative data analysis, you need to create a set of codes to assess your data. In our case, the various parts of the work system. The inclusion of codes was guided by the Systems Engineering Initiative for Patient Safety, or SEEPS model, which states that a work system includes the person, tasks, tools and technology, organization, and physical environment. We took a step further to delineate specific codes within the text. So for the person, there's the prescriber and the pharmacist. Tools and technology includes the EHR, prescriptions, and CancelRx. And for organization, we included the clinic organizational culture and climate. So after we decided what the 6 codes were, we used an expression-based coding approach to automate the process. The platform that we used was Encoder, developed in 2018 by a team at the University of Wisconsin-Madison. Before we could automate our coding, though, we needed to create an extensive codebook. What specific expressions or words would we look at to define the code? So here's an example from our prescriber code. You'll see we have a long definition, an example, and then our expression list. You'll see we included doctor, physician, prescriber, MD, and provider. The Encoder platform requires a human to manually code and to be able to learn, compare, and validate the coding process. Here's our abbreviated codebook, which shows that inter-rater reliability Cohen's kappa scores were all equal to 1 between the automated system and the human coder, which is good and significant. So once all the data is coded, it looks something like this. Each line has a series of binary variables, with a 1 saying yes, this line contains the code, or a 0 saying no, this line does not contain the code. So now we have our clean data with codes, and it's in a format that we can use. We modeled pharmacist and pharmacy administrators' connections between the work system components using epistemic network analysis. The ENA algorithm uses a moving window to construct a network model for each sentence in the data, showing how codes in the current sentence are connected to the codes that occur within the 3 lines around it. In this model, we aggregated networks using a binary summation, in which the networks for a given line reflected the presence or absence of the co-occurrence of each pair of codes. In the resulting weighted network graphs, the nodes corresponded to the codes, and the edges reflected the relative frequency of their co-occurrence. This can all be done online with the ENA applet. You can see a screenshot of the web browser here. The computer takes the text and breaks it down into 4 line chunks, or segments, and it analyzes it, saying if this line has a positive code for pharmacist, say in the next 4 lines what other codes are present. Are pharmacist and prescription often linked together in the same 4 lines? What about prescriber and EHR or clinic? And so just like the name suggests, the computer moves along with this moving stanza of 4 lines, conducting the network. And so it runs until you get a pretty picture. So you'll see here, this is what all the text looks like for our pharmacy leadership and administration. The image shows us that the pharmacy administrators demonstrated the strongest connection between cancellation messages and the patient's electronic health record. You can see the thick green line between CancelRx and EHR. This is represented in the data when a pharmacy administrator stated, "We have access to the electronic medical record, so we can just toggle between a screen, read through the practice notes, and be like, oh, yep, they said they were going to cancel this." The respondent is referring to an instance in which a pharmacist receives a CancelRx from a provider and may have questions as to why the prescription was canceled. The pharmacy administrator states that the pharmacist can look into the patient's electronic medical record and do their homework to answer their questions. This aligns with our image, as the pharmacy leadership had the strongest associations between patient electronic records and cancellation messages, but a much weaker association to providers and other prescriptions. In comparison to the pharmacy leadership, the frontline pharmacist had the strongest associations between new prescriptions and patient electronic records, as well as prescribers and cancellation messages. One particular pharmacist stated they, referring to the prescriber, discontinued the lisinopril before they started the losartan. That being said, if I got a new script coming through in their profile review, I would have seen that and documented it and taken care of it in that manner too. So it's caught, but just because that's what we've always done. But it's kind of cool when it's, referring to CancelRx, done the appropriate way. Ultimately, the pharmacist states that the CancelRx isn't necessary to document the change from one blood pressure medicine to another. They emphasize that they would have captured the same information from the patient's electronic record when the new prescription came through from the provider, but that when they do receive a CancelRx, it's cool to see it functioning appropriately. This highlights that the pharmacist is reconciling multiple inputs when processing any medication discontinuation. The CancelRx is beneficial, but not the sole source of information, and the pharmacist recognizes that this means of communication is not perfect. The results highlighted the importance of assessing implementation of new innovations in terms of an individual's role within an organization. ENA allowed us to go beyond assessing just how pharmacists and pharmacy administrators view a novel health IT innovation, but also how they viewed and framed the problem CancelRx was intended to solve. Pharmacy administrators, removed from the day-to-day workflow of dispensing pharmacies, presented a rather thin depiction of the medication discontinuation process and inferred that CancelRx was a way to communicate information from the EHR with little reference to other components of the system. On the other hand, pharmacists working in dispensing roles viewed the medication discontinuation process as a reconciliation of information from the providers, prescriptions, and the electronic health record. These pharmacists viewed CancelRx as a tool that helped to facilitate the understanding of these information sources, but recognized that it was an imperfect means of correspondence. And with that, I hope you enjoyed this whirlwind crash course of quantitative ethnography as well as CancelRx. If you'd like more information, feel free to contact me at the information provided on the slide, as well as feel free to check out the book Quantitative Ethnography by David Williamson Schaefer, who's sort of the godfather of quantitative ethnography and epistemic network analysis. Thanks so much.